Welcome to this PSPA webinar, which is part of our Ask the Expert webinar series. Today, I'm joined by Dr. Vicki Marshall, who is a consultant neurologist at the Queen Elizabeth University Hospital in Glasgow. Vicki is the lead for the Atypical Parkinson's Neurology Clinic there. So today, we're focusing on questions we've received about treatment and symptom management in PSP and CBD. Hello, Vicki.
Hello, Jules. Thank you for inviting me.
That's all right. You're welcome, more than welcome. Okay, Vicki, our first question today comes to us from a lady who's asking, Janice keeps getting UTIs. Should she be on a prophylactic antibiotics? And do we continue to treat them all?
Good question. Urinary symptoms are common in PSP, and as can UTIs occur frequently. And we've always got to think about why they're occurring. So consider increasing fluid intake if that's necessary. Look at hygiene. Make sure that there aren't any other factors. For example, some people might need a bladder ultrasound to make sure there's no other abnormal process going on that's actually separate to the condition. Repeated or prophylactic antibiotics for urinary tract infections might be appropriate. I suppose it depends on what stage of her condition she has and whether all infections should be treated. That's as the condition deteriorates, and I suppose as we are coming towards end of life, sometimes we do need to ask a question about whether all infections should be treated, try and work out what it is that a patient might want at that stage, and tie it in with quality of life in general. Possibly something to discuss with the GP about whether prophylactic antibiotics would be of use, though. Okay, lovely. I suppose, would the same be said of people maybe who are having a repeated bouts of pneumonia? Is that a similar conversation about whether to continue to treat those? So yeah, that's a very similar conversation, although of course we don't use prophylactic antibiotics generally for regular chest infections. So in relation to pneumonias, often that occurs through poor swallowing and aspiration into the airways. And again, so that depends on the stage of the condition and whether the patient's at that time where it's completely appropriate to continue treating with antibiotics. But if not, then there might be a time when stopping treatment might be appropriate, or giving other supportive treatment other than antibiotics.
Okay, lovely. Thank you. I'm sure that will be helpful. Okay, so moving on, and we started. You said a little bit about swallow there, so maybe this it's sort of on the same level as it were. One question we've had is it still the case that it's best to get a PEG well in advance of it being needed?
Yes, so I think it depends what well in advance, how far in advance you mean. So generally, yes, you do need it to be put in when somebody is still healthy, when it is still safe for them to undergo a procedure, because you need to have healthy skin, you need to be of reasonable weight to undergo a procedure. Once patients are starting to develop swallowing problems, that's probably the time you need to start thinking about putting it in. But you maybe want to have discussions about it even way before then. So always thinking about what would happen, when I lose my swallow, or if I lose my swallow, do I want a PEG tube in, and that sort of thing. But generally, yes, we need to do it much earlier. You don't want for a patient to have lost maybe a couple of stone and then thinking about putting it in, or to have lost their swallow completely, because nutritionally they'll be depleted, they'll be very, very weak. And so you want to try and avoid all of that. That's the idea behind putting the PEG tube in, is to maintain hydration and nutrition and weight, and to keep people strong and healthy. So yeah, early is good.
Okay, lovely. And sort of a little bit of addition to that, and it makes me think, is it something that is necessary, or is it something that people make a choice about having a peg fitted?
Very much a choice. And I think it's reasonable to say that choices change as well.
Mm-hmm.
And, you know, some patients that I've looked after might decide they really don't want a peg tube, that they don't want a tube into the stomach to supplement feeding. But sometimes when it comes to it, they actually, do want it. They change their mind, and that's allowed. Often they don't, and often making the decision in advance is best, because again, the later that you leave it, the more complications you might develop in relation to putting it in. So it's something to be discussed at various time points. Lovely,
thank you. Okay, we'll move on to CBD specifically now, and our questions, if that's okay with you. And somebody's asking about symptom control for single limb involuntary movements in CBD. Is there anything that can be done around this?
Okay, so I suppose this could be a number of different things. So in CBD, we do see patients with myoclonus. So this is jerky movements, particularly when you're going to do something. So action myoclonus is called. And treatment for that will depend on whether the patient is actually disturbed by it. Mm-hmm. If they're not disturbed by it, then you wouldn't necessarily treat it. But you can use different treatments, such as some anti-epileptic treatments, even though it's not a form of epilepsy, can be useful, such as levetiracetam, or you can use clonazepam in low dose. So that potentially could help. It's not helpful always. So the other possibility here, I suppose, would be an alien limb phenomenon. So this involuntary limb movement that you might see, there's different types of it. It could be arm elevation, or an arm that's just doing involuntary grasping, or conflicting with something that the other arm's doing, or something like that. And unfortunately, for that particular symptom, there aren't any medications that will help it.
Okay, lovely. Okay, and another CBD question. So this is from a Parkinson's nurse who says she's been looking after a gentleman with CBD who is now in a nursing home, and his GP is reluctant to increase his pain relief. She says that one of his symptoms is hypersensitivity, particularly in both his arms, unfortunately, where he experiences pain when he's being touched, which is obviously causing quite a problem for him living in a nursing home. Mm-hmm. He's currently having a Convene applied by carers at night, and this procedure is proving extremely painful for him. She's wondering if there's anything or any approach that you found in your experience that would be particularly helpful to help relieve his painful experience, or the relief of pain in general for people living with CBD.
Okay, so pain is something that we do hear about reasonably often with CBD. I think there's always things that we can do, and I'd be interested to hear why the GP is not keen to increase pain relief. I suppose obviously increasing strong painkillers can cause quite a lot of sedation, so maybe that's the concern. But I think there are often different ways in which we can try and manage pain, some of which doesn't involve significant sedation. So firstly, trying to work out what the pain is. It sounds like it's very hypersensitive. I wonder whether you would be sensitive to putting on creams, for example. So initially maybe consider whether anti-inflammatory creams would be suitable. Possibly not. That possibly might exacerbate it because he's so hypersensitive. I suppose apart from the traditional painkillers, you might consider anti or neuropathic painkillers like gabapentin or pregabalin or amitriptyline. Now, some of these things can cause sedation, but actually they can also be very helpful for that hypersensitive pain that patients experience. So that would be another thought. Some of our patients can get really quite rigid limbs and stiff, and pain in association with that, and often don't like to be touched and or for that hand to be moved. So sometimes things like botulinum toxin injections can be very, very helpful to relieve some of that stiffness and spasming that patients experience, just to open up a hand that's potentially quite difficult to clean. So there are a number of different things there. If pain is really difficult to manage, we often would get the palliative care team involved, because they are really expert at managing pain. So that would be another option that is extremely helpful. The other thing to say probably is that there are some antidepressant medications that have the second use as painkillers, so not necessarily as antidepressants. Things like duloxetine and amitriptyline can be used in that way too. So there's lots of different options, and I'd keep pressing for a solution to that. And I wouldn't really take an answer about, well, we just can't increase painkillers if somebody is really in a great deal of distress because of that.
Excellent, thank you. I suppose maybe it's difficult, isn't it? I know I've discussed this with you before. There's some GPs that unfortunately don't come across people living with CBD very often, and maybe that's some reticence in why they might be not or less keen to offer a medication route because of unfamiliarity of the condition, maybe, do you think?
Yeah, no, I totally agree with that, yes. Yeah, absolutely.
Okay. Lovely. And while we're talking about medication and drugs, I've got a couple of questions here for you. For those who have some dopamine response, both in PSP and CBD, what or are there any risks of levodopa? And should there be a withdrawal when people's diagnosis changes from Parkinson's to PSP or CBD, or is it something that could continue?
Okay, so there are side effects with levodopa, and that's why it's always slowly initiated and increased. Side effects can include nausea and dizziness, which often settle down over time. Higher levels sometimes can cause confusion, occasionally can bring the blood pressure down a little bit as well. So you do have to be a little bit careful and cautious with it. But generally, we feel that the levodopa side effects that we see, for example, in Parkinson's patients, are less common than in patients with PSP or CBD. So actually, the general thought is that in patients with these conditions, PSP and CBD, we should be increasing the dose potentially a little bit faster and a little bit higher than we might do than in patients with Parkinson's disease. The reason being, although we generally don't get a very good response with levodopa, we do need to potentially give it a try. And sometimes we need to try it at a higher dose, and if it doesn't work, then we need to bring it back down again. So there can be side effects. We do have to be careful. We certainly wouldn't want to give somebody who is potentially maybe a little bit older with other health conditions. If you give them a very, very high dose of levodopa, you don't really want to crash their blood pressure and cause falls and things like that. So we just got to be cautious and really quite sensible and pragmatic about that. The levodopa response, if there is one for people with PSP and CBD, it doesn't tend to be long lasting, and it doesn't tend to be as effective as for patients with Parkinson's. So it is reasonable to think about withdrawing medication, but some patients will have a response. It might be a mild response. It might be a meaningful response to them, and I think any withdrawal that you do has to come with the proviso that actually, if they do feel worse off it, they can go back onto it. And I think that's okay. That's all right to do that and to maintain levodopa as long as the patient feels it's helpful. Some of the difficulty comes with actually knowing whether it has been helpful, even on withdrawing it. So I certainly have some patients saying, "No, I think I was a bit worse when I came off it, and I'm not sure what happened when I went back on. I'm not sure if it improved." So then in that case, if you're really not sure, if there's no objective measurements, then just coming off it is reasonable. And again, you come off it slowly, so you shouldn't stop it suddenly. That can be quite dangerous to stop it suddenly. You can actually get a syndrome where you can go quite rigid with high temperatures and get some muscle problems. So never ever stop it suddenly. You'd be coming down perhaps by a tablet every week or two or something like that.
Okay, excellent. That's really useful, I think, possibly for some people to know, isn't it? And those people who are living with PSP and CBD who might watch this, that's something to think about, because I think sometimes people may think to themselves, well, it's not doing anything for me, so I just won't take it anymore.
Absolutely, yeah. So
that's I think that's a really important point you made there. Excellent. Okay. Another drug question, sort of carrying on the same theme, is amantadine helpful at any point to manage symptoms in conjunction with or instead of levodopa?
So generally, it's probably reasonable to try amantadine, but in many patients it may not give benefit, and it's unlikely to give benefit on its own. So amantadine is traditionally thought of as something that could perhaps improve gait problems and gait freezing in PSP and CBD. Although it can be helpful for dystonia and kind of rigidity in the body too. Again, it's something that you've got to be careful with, because you can get side effects, it can cause confusion, and if you take it later in the day, it can cause insomnia. So it's all just a careful balance. It's something that might give a mild improvement, maybe worthwhile trialing for a short period, but if not helpful, then come off it. Okay, lovely. After you mentioning insomnia, we'll move on to a sleep question. It flows quite nicely, doesn't it? Okay. So one of the questions we've got here is about poor sleep quality and difficulty in sleeping in general. This person has asked it in relation to her CBD patient cohort. It's something that she finds comes up more often for people living with CBD than PSP, but that may only be in her experience, of course. She's asking, is there a suggested medication or a suggested management route that you could offer? So again, it's about looking at the whole picture about why a particular patient isn't sleeping well. Is it through a pure sleep issue like insomnia, or is it through pain, anxiety, bladder symptoms? Are they not doing very much during the day, so they don't actually need very much sleep? Or are there any medications that are preventing sleep? So, for example, like amantadine, which can cause insomnia in itself. So I suppose what you do also need to know is, if they're not getting very much sleep, is their sleep actually still good quality? Do they really need any more? Do you need to do something about it? So once all of these things are looked at, and if there really isn't anything else there that can be improved upon, like bladder management or pain or anxiety, then I suppose there are some tablets that could be trialed. So drugs like zolpidem or melatonin or short courses of clonazepam, all of which can be sedating. So you do have to watch for a hangover effect the next day, potentially using in short courses as well. But yeah, it can be a problem, but usually it's not just one thing. Often it's it's not just one thing in the whole group. It's lots of different things that are occurring. So still in the sleep zone, I think, probably, but not as well during the day. Restless legs. And this question crops up time and again as a problem for people living with both PSP and CBD. Can you suggest some ways this could be managed? Firstly, make sure there's no drugs that could be causing it. So a lot of antidepressants can cause restless legs. So just consider whether the restless legs started at the same time that the antidepressant was initiated. So that's a good one. That's a nice one to be able to help manage if that's been the cause. You probably want to check iron in the blood just to make sure that there's no iron deficiency, because restless legs is a common syndrome in the general population, and that is one of the first line things that we do. There's iron deficiencies associated with it, and so replacing iron can be very helpful to improve restless legs. Then you'd really be thinking about the non-medical management. So it is about, if you are able to exercise, doing a little bit of exercise in the evening, not too much because that can actually worsen it. Reduce alcohol, caffeine. These things can worsen restless legs too. And then about, I suppose, making the evening a kind of relaxing environment, potentially taking relaxing baths and things like that, or even using distraction techniques. I've had different patients saying that doing things with their mind really takes their mind off the restless legs and helps them manage it without any medication treatment. So there are medication treatments that can be effective for restless legs, though best to speak with the neurologist or GP, but things like gabapentin, pregabalin, even some of the dopamine drugs can be useful. All can cause a bit of sedation, which at night time it's absolutely fine to do that as long as it doesn't kind of fall into the next day. And obviously if it's very severe restless legs, then you'll be getting sedated the next day anyway because you won't be sleeping properly. All right, so there's a few things: non-medical management, monitoring, looking at the drugs, taking away anything, and then trying specific drugs for restless legs can be helpful.
Absolutely, yeah. As you say, I think it's something that isn't necessarily just for people living with PSP and CBD, but yeah. Of course, when that is what you're living with, it's very easy to feel that might be the reason that it's happening, isn't it?
Yeah, exactly.
Yeah. Interesting to hear that there's ways of managing it without taking a tablet, which is
there's actually really good patient information on the Restless Legs UK website. Which is just as relevant to people with PSP and CBD as it is to the general population, to be honest.
Excellent. That's a good nugget of information there for people, isn't it? Okay, somebody's asked a question about anaesthesia, and are there any risks to a person living with PSP and CBD from having an anaesthetic at all?
So it depends how severe the underlying condition is. So if somebody is severely disabled and has difficulty in swallowing, is having regular chest infections, then having a general anaesthetic is going to increase risk of chest infections. So there may definitely be risks in association with anaesthesia in patients. If patients have perhaps earlier onset disease and don't have any issues with swallowing, then it might be much more safe at that stage. And there might not be any concerns, but the anaesthetist is always going to take all of these things into consideration when considering whether it's appropriate to have the anaesthetic or not. Patients should avoid some medications that are commonly used around anaesthesia. So anti-sickness tablets called metoclopramide or prochlorperazine should be avoided because they can actually worsen Parkinsonism. So we avoid that in people with Parkinson's as well. And so, as long as the anaesthetist is aware of the underlying condition, then they should know not to do that. Of course, urgent anaesthesia, you may not be able to avoid that, and that's fine. But as the condition progresses, it may not be appropriate to undergo an anaesthetic, potentially for an elective procedure. So it all depends on what it's for, actually, as well, about whether it's appropriate. But to answer the question, yes, there are higher risks with anaesthesia, particularly as the condition progresses.
Okay, that's good to hear, and I suppose it's always good to let your neurologist know, presumably, if there is a planned operation, so as there can be that joint involvement between the neurologist and the anaesthetic consultant.
Yeah, absolutely, and that's a really common query that we have say from orthopedic doctors or whatever, they'd email us, you know, are there any considerations that we have to take for this particular patient? And that's fine. That's totally appropriate to have conversations like that.
Good. It's good to hear that it works like that as well, isn't it?
Yeah.
Absolutely. Okay. So, I mean, this is quite an interesting one, I think. So, somebody's asked, can you suggest how to help a patient with PSP? This gentleman has excessive saliva and is now also experiencing excessive mucus from his nostrils. He's had ENT tests where nothing abnormal was detected, and has also had some testing around allergies, which hasn't shown anything up either. He does have a PEG in situ, which is not being used at present. It's there ready. The person who sent the question in has said that they're aware that maybe seating posture could be reviewed, but his wife is reporting that at times it's so excessive he's struggling to breathe. Have you any sort of light to shed on this fairly complicated problem?
So excess saliva is really common, really common. It's not actually excess saliva, it's actually a problem with slowed swallowing. So there is pulling of the normal production of saliva. I suppose what I'm not quite sure in that scenario is whether that's related to the excess mucus in the nose.
It's difficult to tell, isn't it, from the question?
That's quite an unusual situation, isn't it?
Mm-hmm.
Not something that I hear about so often. And so some of this will depend also on whether the patient is swallowing or not. If he's not using his PEG, then I presume he is swallowing to a degree.
Mm.
So the initial things that we would potentially do for patients with excess saliva would be to refer to speech and language therapy. They have, they're brilliant in terms of little tips about how to position the neck, how to swallow, actually try and remember, do different things to swallow regularly to try and reduce the pool of saliva that's occurring. Even chewing sugar-free chewing gum can help the brain just spontaneously swallow regularly, so that can help it. And then after that, I suppose we're thinking about other medications to try and help improve. So there's some medications that we tend to try and avoid, particularly the patch medications, because they can cause quite a lot of confusion in patients with PSP and CBD for swallow. But things like things that I found helpful would be atropine eye drops. So these are 1% ophthalmic atropine eye drops placed underneath the tongue, a couple of drops 3 or 4 times a day. So that could be helpful. There is botulinum toxin injections, which could be considered. And these are being done much more frequently. There are different clinics set up in various different situations where patients could be referred to for maybe 3 to 6 monthly injections of the glands here and here with botulinum toxin, which really can help dry up the production of the saliva quite well. So those are the things. I'm not entirely sure about the mucus in the nose and whether that's a separate thing or whether for some reason the saliva is in some way getting up the nose. I'm not entirely sure. I suppose if that is the case, then seating posture would be quite helpful for that as well.
Yeah, it's quite complicated, isn't it?
Yeah.
But saliva is a sort of to extend on that, and saliva is quite an issue for people living with PSP and CBD, isn't it? Some people struggle with the other end of the spectrum, don't they, where they don't feel they haven't got any, and their mouth is very dry. Is there things that can be done about that?
Look at drugs. So some drugs like amitriptyline, which you can actually use for excess saliva, can dry your mouth too much. So you can use artificial saliva for the dry mouth too. You can also get this kind of very, very thick saliva as well. So apparently pineapple juice is very useful for that. for some reason, breaks it down.
That's very clever, isn't it? It is, again, we're back again, aren't we? It isn't always a medication route that works. PSP and CBD, it's often more a management route, isn't it, rather than a medication route. I'm having a look through. We've done well. I think we've covered quite a lot there, haven't we, Vicky? To be honest with you, I think it's always we're always reliant on the questions that we receive, and I think that they've been quite a raft. We've gone through drug medication to symptom management and all around that, which has been really useful. It's been really great talking to you and having you here today. It's
an absolute pleasure.
Yeah, it's great, and not only is it answering the questions, it's getting to see the face of somebody who's working in what is, in the world of PSP and CBD, a fairly unique clinic at the moment, isn't it? Am I right in saying yours is the only clinic in Scotland that's working like this at this point in time?
Oh, I'm not sure about that. We've set up a lovely clinic for our neurology patients in Glasgow, and we're fortunate that you come to join us, Jules, as does Katie Rick from the MSA Society for our MSA patients as well. We're working with physio and speech and language therapist and neuropsychologist, and we have carers support present. And so it's an absolute delight to be able to set something up in the NHS at this time, when things are clearly quite difficult for the NHS.
And thank you very much, and thank you for being the first of our webinars in our Ask the Expert. So it's
not a problem. I hope they go well.
I'm sure they will. Okay. Thank you. Bye.
Cheerio.
Bye-bye.
Bye-bye.